the real incidence of glaucoma after type DSEC is actually not clear because several studies report a range between 0 and 45% of cases. But for sure, a pre-existing glaucoma implies the risk of worsening after DSEC. If it wasn't, if only for the steroids treatment. Endothelial cells that have been implanted, however, suffer from the presence of the preservative. In this study dating back to 2010, it has been shown that not only the corneal epithelium suffers, but also endothelial cells suffer, are damaged, especially by benzaldehyde chloride. The traditional glaucoma filtering procedures, such as TRABE, can cause problems for a number of reasons. First of all, it is possible to cause damage of the implanted cornea, and you might also have an increased risk of failure of the graft due to the rapid decrease of IOP. Or there might be an edema following the surgery due to a hypotone that might cause protracted edema and therefore damage to cornea endothelium. For all these reasons, we've tried implanting in a patient who had received DCK XN45 device. Actually, in the literature, there is no data on such device being applied after endothelial transplant, and so the use of this device is neither recommended nor discouraged. When I performed when I have implanted this device, my case series on glaucoma was about 77 eyes. Out of these 77 eyes, about 80% of them had a good outcome, and a little over 20% required a second surgery or maintenance or other procedures. This is the standard technique we use to implant XN45. So you have the insertion below this valve line of the XN45, and then you rotate the needle once the correct distance from the sclera has been achieved, and then the device is injected. The anterior chamber is washed with BSS, intraocular pressure is increased also in order to favor the bleb formation. Here you may see that the bleb it forms gradually and slowly. So the results in terms of IOP seems to be quite good in these patients. Patients with about 26 millimeters and three different types of eye drops, we achieved about 30 millimeters of mercury. Only 3 of them needed eye drops. So 10 out of 10 patients, 5 required a replacement or the implantation of a second XN45. Some of them needed a new surgery, and 7 draft needling. And some of them had 27 patients had received a phaco emulsification previously, and this may explain why is it that the visual acuity during this year has improved. So the patient I have treated was 83 years old, and she suffered from bullosa, keratopatitis. And so this in last year DSEC has been performed. This is the visual acuity, and this is the surgery. Under air, I have removed the corneal endothelium. I preferred to go for a more exhaustive and more complete rhexis, and then I have retouched it later on to prepare the surface to achieve, to welcome and host the graft. So with my friend Busin and Macaluso injector, I have implanted the flap, and the flap has been fixated with a good result. 3/10, the improvement of the visual acuity. Problem was the pressure, 34 millimeters of mercury, with three different drug active principles, and so we saw that even in such an important glaucoma with an increase in the depression, we may perform this surgery provided the flap is not damaged. So we should visualize the angle, and this isn't very easy due to the endothelial transplantation, but the XEN has been perfectly positioned, and here you may see the injection of the device, and the anterior chamber has been reformed, and the field has been cleaned, and the blood removed, the blood around the device, and so the bleb formed. So the visualization was far from perfect, but the surgery was certainly a success. Post-op, 3 months of cortisone, very frequent pressure controls, and after 3 months the acuity was still 3/10, and then by means thanks to the medical treatment, you may see that the pressure was brought to desirable values. So we may say that the minimal invasive surgery for glaucoma is sufficiently safe and can be used for complex cases. It doesn't prevent any following surgery. Thank you.